Hello and welcome to yet another conference. Today, I'm going to be talking about basics in troubleshooting Ecmo, extracorporeal membrane oxygenation. My name is Dr. PrashanthMuthukrishnan, and I am a pulmonary critical care physician that's very interested in communicating as much as possible through webinars and spreading the message of most up-to-date topics on pulmonary and critical care medicine. I work at Jacobi Medical Center in North Central Bronx Hospital, affiliated to Albert Einstein College of Medicine. Okay, moving on to the next slide. So the extracorporeal life support organization called ELSO has been an excellent resource for worldwide spreading of knowledge about Ecmo and its current practices. So I would like to recommend all of you to make use of the most recent updates that are available for guidelines, general guidelines for all forms of ECLS, as well as certain specific topics such as adult respiratory failure, extubation for people who are receiving veno-venous Ecmo, and so on. Many topics are there. I would highly recommend these topics. Okay, let's start off with some questions. Why don't you name two major trials that looked at Ecmo in adults? And it can be ranging from VV or VA Ecmo. Any guesses? Next, name two examples of material used as membrane for gas exchange. Name one relatively contraindicated sedative when using older oxygenating pumps. Name two companies that make ECLS devices. ECLS, extracorporeal life support devices. Okay. Any guesses on who this is? This is Ms. Esperanza. Okay. And you see that on the left, there is a picture of day one of Ms. Esperanza. She was one of the first cases, neonatal cases of acute respiratory distress syndrome. The original name for the abbreviation ARDS is a neonatal condition. And you see here in 1975, Dr. Robert Bartlett was one of the first physicians to have successfully performed Ecmo for this lady. And you see this amazing woman has actually been participating in many conferences, national conferences, international conferences on Ecmo as of date, and keeps attending these conferences and presents herself as in person for these conferences. Okay, so name the father of Ecmo. Indeed, is Dr. Robert Bartlett, and I'll be talking about him briefly, which is he's a surgeon par excellence, Dr. Robert Bartlett, and he initially started his career in California in Irvine, and moved on to University of Michigan in 1980s, and no wonder U Michigan actually has one of the amazing registries for Ecmo as well. So this is the history of the extracorporeal life support devices. First, we had in the physics laboratory, the membrane oxygenator was developed using many different varieties of materials, ranging from polymethylene compounds, eventually to actually silicone, which is one of the long-term membranes that we have been using for many, many decades, for at least 2 to 3 decades. So first successful case of any form of extracorporeal life support. Although we know that cardiac bypass was already being done around the 1950s, 60s. Then ECLS started being performed in 1970s. and then first pediatric cardiac case in the form of VA, Ecmo, and first neonatal case, Esperanza, as we said, and then trials in ARDS, the first US-based trials containing 9 centers was performed around the 1970s again, and came out as a paper in JAMA that I'll be talking about briefly later, 10% survival. 1990, standard practice for neonates and pediatrics in some centers. 2000, standard practice for adults in some centers that, started practicing them either as salvage therapy for ARDS, or also for other chronic lung diseases where there was bridge towards transplant was also being started at that time. Publication of the Caesar trial happened in 2009, which led to a significant growth in the use of ECMO for ARDS cases. Classic example would be a pneumonia less than 1 week, that actually goes along with the definition for ARDS, where it's something acute illness. ARDS, which is an inflammatory condition, an exaggerated hyperexcitation response to either an infectious or a non-infectious cause of injury to the lung architecture. And here you see PCO2s greater than 100 and PO2s less than 80. And these people have been tried on conventional mechanical ventilation with the VC-AC mode, or sometimes there are some centers have also attempted use of high frequency oscillatory ventilation, although there is always debates regarding the risk benefit ratio of using one versus the other in adults, right? Because so far the trials that came out for HFOV have not shown a mortality benefit. It doesn't mean that it cannot be used. It's just that we have not arrived at the perfect kind of trial, the perfect scenarios where we are able to document the mortality benefit. So as a salvage therapy, there are still centers. For example, University of Iowa is one example where I do remember seeing high frequency oscillator ventilator being used prior to ECMO, or even during ECMO, or such situations have been seen. Proning has also been done for this gentleman, and neuromuscular blockade has been used. So that's when you would find a situation where you can say, maybe we can try ECMO for him. So you see the ECMO here is being used as a bridge to recovery, because you're hoping that this is pneumonia, following which there is an ARDS picture, and I hope that the ARDS will get better and his lungs will recover back towards normal. And so that will be a situation where you would use VV ECMO. As you see, the cannula comes from the IJ and gets into the subclavian, goes through the right subclavian, and then into the superior vena cava. I'm extremely sorry. The IJ and then the superior vena cava, and then right atrium, and then through the right atrium down into the IVC. So this is a cannula that has, so an example would be an Avalon cannula, right? And right internal jugular bicaval cannula, as you see here, yes, and expect 7 to 11 days before recovery. Right, so this would be an example of a case. So what is definition of ECMO? It's defined as the use of a modified cardiopulmonary bypass circuit for temporary life support for patients with potentially reversible cardiac and or respiratory failure. ECMO provides a mechanism for gas exchange as well as cardiac support, thereby allowing for recovery from existing lung or cardiac disease, as per 2014 definition. So the ultimate goal is it can be used as a bridge to either rescue say sometimes used during CPR. We call it eCPR, and or a bridge to recovery, hoping that the lungs will indeed heal or the heart failure will indeed get better after fixing coronary arteries, for example. Bridge to transplantation of either heart or lung or both. Bridge towards destination, such as an LVAD, left ventricular assist device, and bridge to decision and bridge to bridge. Yeah, between two different bridges, between ECMO. You can use ECMO between an LVAD and some other device, for instance. ECMO does not fix the underlying problem, it provides support. It's a transition. Okay, and on the right corner top, you see that the blue color, the venous drainage, comes out from the femoral vein, goes into the machine, goes through the pump in the machine, centrifugal pump. The propeller goes through the membranes in the oxygenator, which also has the same device that helps with the CO2 clearance, and then becomes reoxygenated, and then gets back into the artery here as a femoral artery, right? So that would be an example for a VA ECMO, whereas here and there you see that the direction of flow of blood is up the gradient, right? Is against the usual flow of blood down the aorta, right? And that is very interesting. So here what basically happens is you're using this only because the pumping function of the heart is so weak that there is actually net flow more towards the upper part of the body with the help of the propelled blood from the machine, and there's hardly activity from the heart that's pushing things against the gradient, and then as you see the reoxygenated blood coming up the femoral artery on the left side of this patient will eventually actually feed the femoral artery or the iliac artery of the right side, and some of the blood continues to actually go down this leg. And if there is poor circulation down this leg, then you can always use an additional cannula that goes down the artery on the left leg. It's called a distal perfusion cannula. Okay, whereas down here would be an example for a VV ECMO circuit where you see the deoxygenated blood, the blue color, comes out, goes through the propeller and goes through the membranes, and then you see the oxygenated blood comes back into an IJ, into a vein, goes through the superior vena cava, right atrium, and then right ventricle, and goes through the lungs. Right, it goes through the lungs. So here you are expecting that the right ventricle is actually intact in terms of heart pumping function, and although it passes through the lung, it does not have any meaningful oxygenation in the lungs, and then just bypasses the lungs and goes back into the left side. So ultimately, the oxygenation, whatever it got from the machine, goes through the lungs and eventually goes on to the left side. Okay, so that would be an example of a VV ECMO. Okay. And that would be an example of a VV ECMO with two catheters, right? One in the IJ and one in the femoral vein. Whereas here, in the past few years, we have come up with a single cannula only in the IJ, as I showed you a few slides before, where so right here, what happens is the single cannula has two ports within it. Okay, and there is one port. It all depends on the placement of the cannula tip. And as I see here, let me show you here a couple slides back. Yeah. So So here you see that as this cannula goes down the SVC, there are some ports where in the SVC, and then it passes through all the way into the IVC. So there are some ports that suck blood both from the IVC as well as the SVC. Okay, that's bad deoxygenated blood that's being sucked into one of the ports of the cannula. And then there is another port that is exactly aimed in the right atrium, okay, where the cannula passes through the right atrium, and that will force blood into the as a jet into the right atrium through the tricuspid valve area into the right ventricle. Okay, and that will be actually the return cannula, or the returning port, returning catheter, um, that's aimed exactly at the tricuspid valve. Okay, so, and that is what is actually being shown here, is the returning blood goes also, and it goes through the right atrium into the right ventricle and goes out back into the left side. Whereas the bad deoxygenated blood is being pulled out by two ports. One is in the IVC, one is in the SVC, and then gets into the cannula. Okay, and later I'll be actually showing you a beautiful video that actually depicts this very nicely. Defining the purpose of Ecmo. So first, failure of pulmonary or cardiovascular or both. That's neat. That'll differentiate between VV and VA. Is the process leading to failure actually reversible? If it's not reversible, then maybe there is no indication for it. Maybe the purpose of ECMO is not there. Is it reversible within a reasonable amount of time? Or is the patient likely to die if you have to wait for such a long time because of being on ECMO? If not reversible with recovery, is organ replacement by transplantation an option? So those are considerations where you can use the ECMO as a bridge to transplantation. Considerations, have to be considered in the context of contraindications. So irreversible lung or heart disease in and organ transplantation is not an option, then there's no role for it, right? And massive active hemorrhage, uncorrectable coagulopathy, because ECMO by itself will make you likely to bleed, major active acute intracranial hemorrhage, and multi-organ failure, renal failure, marrow failure examples. Complications, mechanical complications are common, right? Pump failure, membrane failure, air embolism, catheter-related vascular or cardiac perforation, circuit clotting, and hemodialysis. Other complications can be bleeding-related, hemorrhage or stroke in the brain, surgical site hemorrhage, and there can be oozing or bleeding from the cannula tips, ischemia, as well as end-organ, multi-organ failure, stroke, limb ischemia, renal failure, lung injury, and skin ulcerations, infections, syndromes, exposure to transfusion, other blood products, pain, delirium, and definitely, things such as PTSD from being in the ICU and being on ECMO, being on the ventilator, ARDS, post-traumatic stress disorder. Okay, so some of the important terminologies. Access cannula is pulling blood out of the patient, deoxygenated. Return cannula pushes back blood into the patient, and then I mentioned to you about the distal perfusion cannula that goes especially to the lower leg in cases of VA ECMO. Alternative to a two cannula system is a single dual lumen cannula with two ports, right? Access and return both in one. VV and VA ECMO are the two main terminologies. Oxygen content of the blood is an extremely important measurement. Diffusion of gases, carbon dioxide and oxygen are measured in partial pressures with the help of ABG samples. Carbon dioxide transfer is 6 times easier and faster than transport of oxygen. Okay, and that it's an important issue as you will see in adjusting things on the sweep gas and also trying to liberate the patient from the ECMO, you'll see that the oxygenation happens much slower compared to the carbon dioxide recovery. And the delivery of oxygen, as you know, is a combination of cardiac output and the oxygen content, right, times 10 to correct for the difference in the units, 1.34 times the oxygen saturation of blood and the hemoglobin, plus a very small component of the PaO2. Normal content of oxygen ranges around 20 cc's per deciliter in the arterial side, whereas on the venous side, usually 5 cc's is being pulled out. That's around 15 cc's per DL, and oxygen consumption is around 200 to 250 cc's per minute. So this is one example of the dual, the two catheter system, right? Okay, so here, two-side approach to venous ECMO cannulation. Here you see that the tip of the femoral venous cannula goes up all the way into the IVC, okay? And there is a problem in this cannula because what happens is oxygenated blood comes back down the SVC and there is some amount of oxygenated blood, as you see here, fresh oxygenated blood, just because the jet is being directed like this. Some of the oxygenated blood gets pulled into the IVC and actually gets pulled into the access cannula. And this is called as recirculation. And this can be avoided when we use the dual lumen cannula system, because avoided in the sense, not completely avoided, but much, much better managed when the dual lumen cannula is there, because this concept of recirculation is taken care of because of the arrangement of the cannula. Okay, so this will be an example of the Avalon, for example, is the dual lumen.
DLC is designed to enable optimal extracorporeal support for patients with acute and chronic lung failure. Our use of a new hybrid polyurethane silicone material and stainless steel spring reinforcement provides strength, flexibility, and high flow rates. Its patented dual lumen design incorporates a collapsible membrane to support simultaneous removal and return of blood from a single insertion site. The bicaval DLC is inserted through the right internal jugular vein. Upper and lower drainage ports are located in the superior and inferior vena cava, and blood returning from the external circuit exits the cannula in the right atrium. The bicaval DLC simultaneously balances the removal of deoxygenated blue blood and the return of oxygenated red blood to minimize recirculation. This superbly engineered cannula is a major advancement in the practice of extracorporeal life support therapy.
Excellent. So I think that definitely made more sense than when I was trying to explain that without the help of a picture. Okay. Moving on to the next slide. So the membrane that is being used for gas exchange, as I was asking you before during the question and answer session, was initially silicone for many, many decades. And now we have moved on to a newer material called polymethylpentene. And one of the important facts is that the membranes have gotten so much better these days that there is hardly any resistance that the membrane poses to the movement of blood, oxygen, and carbon dioxide. Um, and so at this time, it's just literally the resistance of the blood itself that's the affecting factor. And there is one important thing to know, which is propofol happens to interact with the silicone membrane when used as a sedative, right? And therefore, you have a likelihood of plasma leak that can happen when you use propofol, especially for a longer period of time. So, and that's one of the reasons why we've moved on to polymethylpentene. Um, and just a brief history behind the use of the silicone membranes. William Kolff was one of the first people to invent the membrane, the semipermeable membrane, which was actually used in the dialysis machines first, and then also used later for the Ecmo machine, and then later popularized by John Gibbon. Okay. Okay, oxygenation first is the most important part of Ecmo, and then also comes ventilation, okay, which is carbon dioxide. So for oxygenation, the main mechanism is increasing cardiac output, okay, or increasing the flow of blood through the circuit. So unlike the ventilator where you crank up the FiO2, here we have to crank up the output, the amount of blood that's flowing through the oxygenator. That is going to affect the oxygen levels in the blood. Okay, so that's number one. Number two, preload and afterload dependent flows. Okay, which means that the amount of preload in the body will also affect amount of total blood that's circulating through the body as well as through the machine, and therefore any significant drop in the preload, for instance, of the body is going to affect how much blood you have available to go through the circuit. Okay, the maximum amount of flow that you can get out of these systems, the equipment. Say, for example, some of the companies like Macket or Metro or Tandem, Nova Lung, you can reach a maximum of 5 to 6 without any trouble. And once you head towards 7, it's really going to be a problem. So that's something to know, that these equipments have limitations on the maximum amount of flow that you can achieve. Maintaining pressure ranges at the inlet and the outlet is very important, just like we have in the dialysis machines where you keep monitoring at the negative pressures at the access site. Here we try to range it between -100 to -300, and at the outlet somewhere less than 400. Oxygenator membrane lung is a bunch of hollow fibers, microporous material, and usually has a 30-day life. Okay, so these membranes actually, have to be changed very much frequently. Nowhere close to 30 days. Okay, so that's the maximum life. Oxygenation again depends on the surface area available of the membrane and also the thickness of the membrane. And usually we get ABG's Q4 hours coagulation labs because of the hemolysis that happens, and also because of the heparin that's being used for the circuit twice a day. And we check the rotations per minute and the flows every 1 hour to chart. And these are perfusionists that are doing these jobs. and sometimes in other places, the respiratory therapists or the fellows. Inline labs are very useful, so you don't have to poke the patient multiple times. Post-oxygenator blood gas is one location where you obtain just after the oxygenator, before it goes into the patient. So that's number one location. Number two location is in the patient itself. An example would be a patient's radial artery, ABG, to look at what's going on the left side of the patient, left side of the heart, sense the cardiac output. And also the third one would be, what are you pulling out of the patient from the drainage cannula? For example, if you're pulling out from the patient blood that's super oxygenated, then it means that you are probably, either the patient is getting better, slightly better compared to before, or you're just pulling out blood that you just give to the patient that's oxygenated. Okay. Ventilation is the next question. So number one, it's proportional to the membrane surface area again. On the sweep gas, which is the gradient of the carbon dioxide across the membrane. Okay, so amount of gas that's swept from the deoxygenated blood out into the equipment, and then gas diffusion gradient. Now, carbon dioxide is independent of blood flow. You can crank up the RPMs for the equipment as much as you want, but that's not going to affect your carbon dioxide. Okay? It's purely dependent on the sweep gas and the diffusion gradient. And the most important reason why carbon dioxide exchange is much quicker and more efficient than oxygen is because of solubility of carbon dioxide in blood and in the membranes. In fact, this is one of the reasons why restrictive lung diseases, for instance, ILD, restrictive pathology, you will notice that interstitial lung disease patients actually rarely present with carbon dioxide issues. It's mostly hypoxia. And that's because carbon dioxide is super soluble, that it doesn't really get bothered in restrictive lung diseases. Oxygenation is diffusion limited. Okay, and examples from TANDEM or NOVA lung. Here you see the oxygenator is actually pretty sleek in this machine. That's the pump, and it's pretty portable, very portable, friendly. See, this is the kit that you can attach it to the patient, and these are two examples of images that have shown. One is the port, the receiving port in the right atrium, whereas the access port, which is the oxygenated blood, can actually come out way distal in the pulmonary artery. So that's one example, whereas the other one is very similar to the one that we showed before, which is the right atrium is the site of oxygenated blood coming back into the heart, whereas the IVC site is the drainage cannula. Okay, and this is one of the examples for, how would you prime the circuit?
Real quick. So what you normally do, the biggest thing, you want to record this? Yeah. Perfect. I love it. So the longest part about priming the circuit is getting 4 liters of normal saline into this priming basin. So the pump oxygenator comes in here all sterile. The priming tray is sterile. So take everything out. Put 4 liters of normal saline in here. Connect blue to the blue, red to the red. You want this level, the pump level. Come on, Todd. So you want the level like this, right? Is going to gravity prime to the pump head. Start doing it for you, right? And if he needs a little help, he just use a little bit of physics. Okay. And then at this point, you want to hit pump start. Pump starting, and it's starting to prime. You have a prime circuit. Wow. Quick, simple, easy, repeatable, right? So now you clamp. Okay. You're ready to connect to the canyons. Okay. How long did that take? Pretty quick, right? So it's something you can do repeated, like say when you start someone on circuit, right, it takes a lot. Everyone's nervous and everything. So he's going to DR real quick. So what you normally do,
And battery life is somewhere about 60 to 90 minutes. So easily portable from one hospital to another, from a site to an ECMO site.
148.
And they have wonderful educational videos. So Macket and Tandem are two of the major companies. So Macket, as you see an example here, this is the cardio help. You have the touch screen, and these are some of the knobs, the EKG ports, the power supply, alarm output. And this is the rear view that shows you the red color oxygenator, and some of the sites where you can actually connect the sensors and the ports where you can actually draw blood, post-oxygenator blood. This is the typical screen on the pump, where you have the flow, which is in liters per minute, RPMs, which are rotations per minute. Okay, and then here you actually have an inline monitoring for the ABGs, and it shows you the venous blood gas. Sometimes you're able to see what the SATs are on the venous side. Here you can also see what's the pressure, the negative pressure on the venous side and on the arterial side. Okay, you can continuously monitor what are the negative pressures, and that's also visible. And then the PVNS and PR are the measurements of partial pressures. Okay, and the venous SAT. Pump in the oxygenator. Here you see the different portions of the oxygenator with the gas inlet, the centrifugal pump. And here on the right, you actually have the infrared detector for the blood gas, basically. So coming back to the answers for the question, so two major trials would be Eolia, which just happened in 2018, got reported in 2018, and it's been done for over 5 years of planning and 5 years of execution. Caesar trial came out in 2009. Two examples, silicone and polymethylpentene. Name one relatively contraindicated sedative. I told you with propofol with older agents with the plasma leak. And two companies, Macket, Loa, Lung, and Meadows. Okay. So this is part one. Why don't we take a break and actually continue on to the part two, where we'll talk about the trials as well as talk about troubleshooting of ECMO. Okay. I'll catch you on the next slide. Thank you.